Hi, good evening. Thank you for coming back, and today I'm going to start with a new chapter, antitubercular drugs. Antitubercular drugs. Now, antitubercular drugs, they are mainly given for treating tuberculosis. Now, what is tuberculosis? Tuberculosis is a granulomatous disease which is chronic in nature, and it affects a majority of the population, especially in the developing countries, and it is mainly caused by Mycobacterium tuberculosis, and it's very much communicable in nature, so we need to be extra careful, and we need to treat the tuberculosis as early as possible once the signs and symptoms are noticed, and we must ensure that the patient takes the or completes the treatment regimen completely, otherwise it's not going to properly cure the patient. All right, so for those particular purpose we have anti-tubercular drugs. Now certain drugs we can't go for giving it or administering it all alone. Sometimes on constant administration it can go for causing a resistance within the particular organism, and as a result the particular drug stops acting on it. All right, so sometimes they go into a state called as a multi-drug reactions. So in order to avoid such kind of particular things from taking place, what we go for doing is we go for administering it in combinations, so that the resistance towards a particular drug doesn't happen. And also infection can be cured under proper strict surveillance has to be carried out. Only on that basis we can go for properly curing the particular disease. Now if you see the anti-tubercular drugs, they are classified basically into two ways: first line drugs as well as the second line drugs. First line drugs and second line drugs. Now first line drugs, they have said to have a very good and highest anti-tubercular efficacy, and it is very low in toxicity, and as a result of that they are used very routinely. When we go to second line drugs, they have either low anti-tubercular efficacy or high toxicity, or both, and they are used in special circumstances only. Okay, so two ways we classify it: first line drugs and second line drugs. First line, it holds a very good efficacy or high efficacy can be seen, low toxicity, and as a result of that they are used routinely. Whereas the second line drugs, they have either low antitubercular efficacy or high drug toxicity, or even both, and they are used only in specific or in special circumstances. Now let's see what are the drugs that comes under first line drugs. So we have isoniazid, rifampin, pyrazinamide, ethambutol, and streptomycin. So we just have 5 drugs: isoniazid, we have rifampin, pyrazinamide, and we have ethambutol and streptomycin. Moving over to the second line drugs. Second line drugs, we have a little more number. Okay, so we have thiacetazone, para-aminosalicylic acid, ethionamide, cycloserine, kanamycin, amikacin, capreomycin, ciprofloxacin, ofloxacin, clarithromycin, azithromycin, and rifabutin. Thiacetazone, para-aminosalicylic acid, ethionamide, cycloserine, kanamycin, amikacin, capreomycin, ciprofloxacin, ofloxacin, clarithromycin, azithromycin, and rifabutin. So these are the two ways an anti-tubercular drug has been classified: first line drug, and we have second line drug. first line drug we have 5 drugs, and second line drug it has got 12 drugs. Alright, so let us start off with isoniazid. Isoniazid, it's otherwise called as isonicotinic acid hydrazide. Isonicotinic acid hydrazide. So it is an antitubercular drug. Since we are discussing it under antitubercular drugs, it is an antitubercular drug, and it is an essential component of all antitubercular regimens. Okay, it is an essential component of all antitubercular regimens, and this can be routinely given, or this can be given to the patient as long as the patient is able to tolerate it, or the bacteria does not turn out to be resistant to that drug. Alright, till then this particular drug is said to be very safe to a patient. The patient can tolerate it, as well as the resistance power of the bacteria is very low towards the particular drug. And it's said to be bactericidal. Tuberculocidal. Okay, it's said to be tuberculocidal, and it is very effective on fast multiplying organisms. So it gets the particular bacteria which is undergoing or dividing very fast or rapidly. They have a very good impact on it, but the quiescent ones are only inhibited. The rapidly multiplying ones get killed, whereas the quiescent ones, they are inhibited. And another important aspect that we can have is it acts even on the extracellular as well as intracellular tubercular bacilli. Okay, so it's going to act upon extracellular, because there are certain drugs which acts only in intracellularly, whereas some only on extracellular. But here we have a plus point, that is, it's going to behave in both extracellularly as well as intracellularly, and also based on the medium. Okay, whether acidic or alkaline, in both the medium it is very active, and it is very cheapest. But mycobacteria atypical, okay, the atypical form mycobacteria is not inhibited by isoniazid. Okay, the most of the atypical mycobacteria are not inhibited by isoniazid. Okay, so there are certain important things that you need to remember. It is an antitubercular drug, and it forms an essential component of the antitubercular regimen, and as long as the patient can tolerate it, or the bacteria is not resistant to that particular drug, we can go for routinely using it. It is tuberculocidal, and even the rapidly multiplying organisms are very much prone to it, but the ones which are in the quiescent phase, or the quiescent ones, they are only undergoing inhibition, and they are very active on the extracellularly as well as intracellularly, even equally active in alkaline as well as in the acidic medium. However, most of the atypical mycobacteria are not inhibited by isoniazid. Now, how it is going to act, the way it's going to act, or how it's going to act in the body, mechanism of action. So what it does is, it goes for inhibiting the synthesis of mycolic acid. Okay, it goes for inhibiting mycolic acid. Now, mycolic acid is a important fatty component which is present on the mycobacterial cell wall. It is an important component, a fatty component present on the mycobacterium cell wall. So if the mycobacterium cell wall, the fatty component is not fully found, then the particular bacteria is very susceptible to get killed. Alright, so the mechanism of action is, it inhibits mycolic acid, which is an important or essential fatty component responsible for the mycobacterial cell wall. Now, in which are the ways we can find resistance? Okay, one is if there is a mutation. all right, if there is a mutation, or the the particular mycobacteria or the particular organism shows resistance. So in any of these ways, the resistance can happen inside the body. Pharmacokinetics. How does this particular drug undergoes absorption and all? So if you see, isoniazid is completely absorbed orally. All right, it is completely absorbed orally. It penetrates all the tissues, including tubercular cavities, placenta, and meninges. Okay, all the tissues, that is all the body tissues, tubercular cavities, placenta, and meninges. It undergoes metabolism in the liver. That is the most important pathway is acetylation, and here the metabolites are excreted in urine. The metabolites are excreted in urine. All right, so in simple way, if you see, it is completely absorbed on oral administration. It penetrates through all the body tissues, the tubercular cavities, placenta, and even meninges. It undergoes metabolism in the liver. Basic pathway is acetylation, and the metabolites are excreted out in urine. Now, interactions. Okay, what happens, or what are the changes, or what are the interactions that takes place when we administer this particular drug with another drug? For example, aluminum hydroxide. If you are giving aluminum hydroxide with isoniazid, it is going to inhibit the absorption of isoniazid. Aluminum hydroxide inhibits isoniazid absorption. Isoniazid will inhibit phenytoin, carbamazepine, diazepam, and warfarin metabolism. Okay, it's going to inhibit phenytoin, carbamazepine, diazepam, and warfarin metabolism. So if the metabolism doesn't take place, these drugs are going to remain inside the body. So simple words, if I say, the blood levels of these drugs are going to be raised inside the body. It can go for toxicity. All right, and para-amino salicylic acid, which comes under the second line drug. It will inhibit isoniazid metabolism and prolongs its half-life. So these are the interactions we need to remember. Okay, if if aluminum hydroxide is being given with isoniazid, we should remember that it's going to inhibit isoniazid absorption. Isoniazid will inhibit phenytoin, carbamazepine, diazepam, warfarin metabolism. As a result, their blood levels are going to be raised. And para-amino salicylic acid, which is a second line drug in antitubercular regimen, it's going to inhibit isoniazid metabolism and is going to prolong its half-life. Adverse effects. Usually isoniazid is said to be well tolerated, but we can find peripheral neuritis and a wide variety of neurological manifestations. Okay, so peripheral neuritis can be noticed. Apart from that, neurological manifestations like paresthesia, numbness, mental disturbance, and very rarely convulsions. Paresthesias, numbness, mental disturbance, and very rarely convulsions. These are dose-dependent toxic effects. Dose-dependent toxic effects. Okay. Now, this can be reduced when we go for administering pyridoxine. Okay, pyridoxine, if we are giving 10 mg per day, it will prevent this neurotoxicity. Okay, even if it is given at higher doses. Okay, that particular drug is given along, even with higher doses also, we can go for reducing this neurotoxicity, but its regular use is not advised. Pyridoxine's regular use is not being advised. Okay, and so in such kind of cases, we can treat it by administering 100 mg per day. 100 mg per day. So usually prophylactically we go for administering 10 mg per day, whereas for treating this neurotoxicity which is caused by isoniazid, we go for administering 100 mg per day. The other common side effects which we can notice is rashes, fever, acne, and arthralgia. Rashes, fever, acne, and arthralgia. Okay, so this is all about isoniazid. So isoniazid, just want to sum it up. Okay, so isoniazid, antitubercular, it is basically tuberculocidal, and it is an essential component in the treatment regimen if you take, and as long as it is easy for the patient to tolerate the drug, we can continue taking. As long as the particular organism doesn't show any resistance, we can go for administering it. And advantages are it's very active, or it reacts even extracellularly as well as intracellularly. If the medium is alkaline or acidic, this particular does not pose any problem to this particular drug. This drug will carry out its action in any ways. Except most of the atypical mycobacteria, they do not they do not react, or they do not respond to isoniazid. So how does, or the mechanism of action of this particular drug is, they will be inhibiting mycolic acid, which is a fatty component essential, important for mycobacterium cell wall. And in which in all cases we can find resistance. One is by mutation, or another way is when the patient was on continuously on this particular drug, automatically the body doesn't respond for it. So such way resistance can also happen. Or in other way, if the organism is resistant to that particular drug, then in such ways resistance can be noticed. Pharmacokinetics, it is completely absorbed orally, and it penetrates all the body tissues, tubercular cavities, placenta, and even meninges. After that, it undergoes metabolism in liver. Basically, acetylation will be done, and its metabolites are excreted out in urine. Moving over to interactions, aluminum hydroxide will inhibit isoniazid absorption. Isoniazid will inhibit phenytoin, carbamazepine, diazepam, and even warfarin metabolism, thereby raising its blood levels. And even para-aminosalicylic acid inhibits isoniazid metabolism and prolong its half-life. Adverse effects, if you see, usually it is well tolerated, but in case if the dose related or dose dependent toxic effects happen, mainly it is a peripheral neuritis and certain neurological manifestations like paresthesia, numbness, and sometimes, very rarely, we can see convulsions, and even mental disturbances can also be noticed. And this particular neurotoxicity can be brought down if we prophylactically, before the starting of it, if they prophylactically start off with pyridoxine 10 mg per day, it is well good. Even if we are administering the particular drug in higher doses also, if we go for administering pyridoxine, it will work out well. Otherwise, if the toxicity has already been started, then we have to administer 100 mg per day. And other side effects that we can notice is rashes, acne, fever, and arthralgia. So with this, I have completed isoniazid. So I hope you have understood the class, and so tomorrow I will be continuing, on next class I will be continuing with the remaining first line drugs. So till then, take care. Bye bye.